prolactin, TSH, ACTH, LH, FSH. In this lecture, we will focus on first two, growth hormone and PRL, prolactin, not on the others because these are covered in the other part of the modules. Okay. And posterior pituitary hormones are ADH, antidiuretic, and oxytocin. So we will focus on ADH, not on oxytocin, which will be covered in the other module. Okay, now coming to the hyperfunction. So our lecture will be divided into hyperfunction and hypofunction, when there's more secretion and when there's less secretion. So this is how our lecture will be divided. So anterior pituitary hyperfunction disorders, these are usually divided into primary and secondary. What is primary? Very good. So we are talking about pituitary means pituitary problem. Okay? Or when we will talk about adrenal, it means adrenal problem. Secondary means due to other causes. Okay? Due to other causes. The same result is there due to other causes. So primary defect in gland itself and secondary defect is somewhere outside of the gland. Okay, for example, growth hormone, releasing hormone from hypothalamus. So growth hormone is more, but the cause is hypothalamus, not the pituitary. Just an example. And hypopituitarism means, hypo means less. Okay, so clinical syndrome deficiency of these hormones, pituitary hormones, which may be single or multiple. So maybe one hormone is less or maybe multiple hormones are less. So it can be either. And it can be due to disorders of pituitary itself, maybe adenoma of pituitary, the benign tumor, or hypothalamus problem, or some other surrounding problem, some other thing compressing these pituitary and hypothalamus. So pituitary tumors or adenomas are the most common cause of hypopituitarism. So these tumors are the most common cause. And panhypopituitarism means total absence of all pituitary secretion is very rare. It's not very common, it's rare that all hormones are less. Postpartum pituitary necrosis is the most likely to occur in women with severe blood loss. So this is one of the known cause that after delivery there is necrosis which can lead to that, and it can be a complication of radiation therapy, or total destruction of pituitary gland results in different symptoms like weight loss, emaciation, atrophy of the endocrine glands, hair loss, etc. And common death may occur. So this is just one point you should know, that this one term called panhypopituitarism means that all hormones are finished or almost absent. So this is rare, not very common, and one of the known common cause is this one after the postpartum pituitary necrosis. So now that this is the important part of the lecture now. After this background of the pituitary, now we are stepping into the important part. How these anterior pituitary hyperfunction is assessed, how it is assessed. We are talking about the diagnosis. How we can diagnose and label a person that he is suffering from hypopituitarism or hypofunction of anterior pituitary. So first of all, clinical examination. We cannot bypass clinical examination. Without history and examination, we cannot label somebody that he is suffering from hypopituitarism. It's a very important point. Examination and history is most important thing. After that, other important thing is radiological investigation. If the clinician is suspecting that person has some pituitary adenoma, for example, I have said that is most common. So maybe pituitary adenoma, so go for these investigation, CT or MRI or whatever. And lab investigation will also play their role after these things. In other words, if I will say that only lab investigation will not help. This is the key point. Only lab investigation is not enough to label somebody that is suffering from anterior pituitary hyperfunction. Got it?
No, sir, thank you.
So only lab investigations, laboratory investigation, which we will discuss. If they are not up to the mark, we will not label that this person is suffering from pituitary hyperfunction. Only lab. We have to look into the history we have to look into the examination, we have to go to the radiological investigation. In other words, only lab will not help. We have to do other things also. Okay? If some report, growth hormone report becomes, okay, growth hormone is less, I will label that this person has growth hormone deficiency? No. I have to look into the history examination also. This is the first important point. So now the growth hormone deficiency. So I told you anterior pituitary, posterior pituitary. In the anterior pituitary we will talk about mainly about growth hormone. Okay? And the posterior pituitary will talk mainly about ADH. So regarding the growth hormone deficiency. So first of all, the important point in growth hormone that it has a pulsatile release. What is pulsatile release? In a wave manner. Sometimes increases, sometimes decreases in the normal routine. Okay? So it means only the single reading, single investigation will not help. For example, person goes to the lab or doctor after history examination ask him to go to the lab for the blood growth hormone. So, and readings is below the normal. So I will not label that, okay, he is growth hormone deficient. Only on the one reading we will not label. Okay? So we need at least two or more than that evidence that he has growth hormone deficiency. Got it? Not only one report, not once. It should be multiple times, 2 or more. And other tests should also be done. So we can divide the test into screening test and confirmatory test. Okay? Screening. What is screening? To find. I just screened all the people. And then if some suspicion, then I will go to the other test. Confirmation. Okay? So first test is growth hormone testing. We will test what is the growth hormone level. And it should be done after fasting, overnight fast. Okay? So if it is abnormal, then means it is below normal, so then we will go for confirmatory test. Okay, first test is growth hormone level. If it is abnormal, we will go for confirmatory test. Other thing is measurement of IGF level. Okay, this is also growth. It is one of the growth factor which is helpful in this growth hormone deficiency labeling. Okay, so it is helpful mainly in the children, not in adults. This is an important point regarding this. That this IGF-1 level is important in children, not in adults. Because up to 1/3 of adults have to be proven that growth hormone deficiency, they may have normal serum IGF level. So in other words, in adults it's not so significant, in children it has a significance. Got it? So first growth hormone level, IGF level, IGF-1 level, okay, important in children. If it is below normal, again we will go for confirmatory tests. These are screening tests, okay, these are not confirmatory. Means I will not label a person that he is suffering from growth hormone deficiency after looking at this report only. I will go for confirmatory tests also. Are you getting this point? Screening, confirmation. Screening, growth hormone. Number 2, IGF-1. Other thing is growth hormone measurement following exercise. A person does exercise, we measure the growth hormone. This is also called exercise stimulation test for growth hormone. So what happened? Rationale. What is the meaning of rationale? Rationale means the reason why we are doing this test. What will be the benefit of this test? What is the background of this test? Okay? So rationale, the English word means the background or the whatever you say, the reason of this test or logic of this test. Okay, brisk exercise normally causes an increase in growth hormone. So this is the logic. That brisk exercise means excessive exercise, too much exercise. It increases the growth hormone level. So we ask the person to do exercise and we measure the growth hormone. What should happen in a normal person? It should increase. But if a person is growth hormone deficient, will it increase? So this is a simple idea. Okay, so don't worry about the values. Okay, this is also key message of this lecture. There will be too many values. Don't worry about this. You should have a concept only. Okay, that if increased, because if in exam it will come, the normal range will be given. Okay, so only you should remember the concept increased or decreased or normal. Okay, so don't worry about the values. So in a normal person, it should increase, but in growth hormone deficient, it will not increase. But this test should be followed by a confirmatory test. Okay, this is an important point. Okay, other thing is pharmacological growth hormone screening. So different agents are there: clonidine, glucagon, L-dopa. So we give these agents to a person. So what happens usually after administration of these agents, the level of growth hormone should increase. The same idea. These agents increases the growth hormone in a normal person. But if a person is growth hormone deficient, what will happen? No, not increase, because he is not responding to the stimulus. Okay, this is also key idea. There will be word stimulus using again and again this lecture. What is stimulus? Some trigger. Very good. This is a good word for that. Trigger. We give some trigger to the body and we will see the response of the body. So this is a trigger. This is a stimulus to the body. These all agents, exercise, these are triggers and these are stimulus to the body. We look for the response. Normal response or abnormal response. Okay. So till now we have discussed in this lecture that we are talking about pituitary disorders. We are now in the hypofunction of the pituitary. We are in the anterior pituitary and we are taking the growth hormone. In the anterior pituitary we are focusing on growth hormone. Okay, growth hormone deficiency, in other words. I have told you that they are screening tests and confirmatory tests. Okay, so there are 3 tests we have discussed: the screening, growth hormone or IGF level. Number 2, exercise test. On number 3 is these agents. Okay. Now the definitive test, confirmatory test. This is important. Now after those tests, history examination is there. Okay, history examination we have done. Then those tests were done, screening test. Everything is in favor. Now we are stepping to confirmatory test. So insulin tolerance test. So same logic. That growth hormone responses to centrally acting. Okay, insulin or arginine. We give insulin or arginine. The idea is same. What does insulin do? Very good, hypoglycemia. What should be the response of growth hormone? It should increase. In a normal person, after the hypoglycemia, the growth hormone level should increase. So same idea is there. So we are giving insulin, hypoglycemia is occurring, growth hormone level should increase in a normal person. But in a growth hormone deficient person, what will happen? It will not increase. Simple. So this simple logic is there. And same thing happens to arginine. Yes, please.
It's still normal, the normal level.
So we will not label. If after this test the level is normal growth hormone, it means there is no problem with the growth hormone. Okay, that's why we are doing this test. So this is also called insulin tolerance test. Okay, insulin tolerance test. That body tolerates the insulin. What is the meaning of tolerate? that it bears, okay? It has a resistance or whatever you say. So what happens to the body? It tolerates or not insulin. So that's why we call it insulin tolerance test. So this is a gold standard. Considered to be gold standard stimulus when hypoglycemia is indeed achieved. So it is a gold standard to label a person that he is growth hormone deficient. So after this insulin, we measure growth hormone and cortisol also. Cortisol should also rise as growth hormone, because when we are giving insulin, hypoglycemia, it should raise cortisol and growth hormone. So we measure both. We can measure both. So serum growth hormone should rise to some level. I'm not focusing on the values. Just remember it is high. And serum cortisol also rises. No or inadequate response indicates pituitary or hypothalamic lesion. So there is some pituitary lesion or hypothalamic lesion is there if these levels are not rising. Are you getting this point? Whenever we have a problem, just stop me, okay? The second I told arginine, we give arginine stimulation test. The same rationale, logic. In normal, IV administration leads to growth hormone release. So normal response is growth hormone rises. After that, a subnormal response, abnormal response occurs in growth hormone deficient patient. But at least 2 stimuli. Again the same concept, or not only one, at least 2 stimuli should be given, insulin and arginine, to label a person growth hormone deficient. Important point. Because you are labeling a person growth hormone deficient. So how can you do after one test or one report? It's very important diagnosis. Okay? Yes, please.
Is it only insulin arginine or
No, usually it's on all tests, but because these are confirmatory tests, there's a confirmatory test. So here it's more important.
So we need one initial test and 2 confirmatory.
Yes, to label a person growth hormone deficient. Okay. And one additional point, we should also look for thyroid gland before labeling a person. If it is hypothyroidism, then it must be corrected. Okay. So this is an important point. Okay, I will just repeat this point. Okay, it's not very difficult, just focus on that. We are talking about growth hormone, lab investigations, laboratory investigation of growth hormone deficiency. We are talking about that. Growth hormone deficiency, how can we label a person growth hormone deficient? History examination, we will take the history, we will ask, we look the patient, where stature, how much is stature, growth, everything. Okay? Then along with that, CT and MRI, if there is suspicion that he has this deficiency. And thirdly, we are talking about investigations, laboratory investigation. I told that there are few screening tests and there are few confirmatory tests. Okay? Screening test, I told growth hormone level, we'll check for growth hormone level, but not once, 2 times at least. Number 2, IGF-1 level. Okay? Then exercise tolerance test, mean what happens to after exercise. In a normal person, growth hormone should arise. Okay? And there are few agents are there, we give them clonidine, L-Dopa, etc. and we look for the reaction. These are screening. Then the confirmatory test. Confirmatory test is we give insulin to create hypoglycemia, which should rise growth hormone in a normal person. But in these patients, it will not rise. Growth hormone will not rise. This will confirm that, okay, this person is growth hormone deficient. Are better now? Or arginine, we can give the arginine. Or both. Both should ideally given. Both should be given and both should confirm that this person is growth hormone deficient. Better? Somebody asked here. You? Back. Anyway.
Single time, last time or multiple times? Insulin and
No, if they both are given before that, screening tests are also were there. So once, if both are giving the same report, once enough. But if one test you are doing, it should be done more. Okay, this is just the values. I've talked about that. No, there's no significance for that. Okay, so growth hormone deficiency we have finished. Now, prolactin deficiency, prolactin. Okay, we will talk about these two only as far as anterior pituitary is concerned. Okay, okay, serum prolactin level. It should be overnight fast, after the overnight fasting. The important point in this that these patients are usually asymptomatic. What is asymptomatic? There is no symptom. Okay, so if there is no symptom, why should we do that? Obviously, there is no reason. Patient will not go to the doctor, and no test will be given. So that's why the significance is less than growth hormone. Okay, there is no too much significance of this test. Rarely necessary. So it's very rarely done because asymptomatic patient, it will not go to a doctor. Okay, so in other words, the prolactin deficiency is not too important. Growth hormone deficiency is very important. So I talked in detail. Now the anterior pituitary hyperfunction, hyper, more. Okay, we have discussed the hypo. Now hyper. So hyperthyroidism involves one single hormone except in certain hormone secreting tumors. So usually one hormone is more, but in some tumors more than one hormone means growth hormone, other can also rise. And the most common causes again adenomas, pituitary adenomas or prolactin secreting adenomas. So these adenomas are the common cause. The adenomas occur, they lead to increased secretion of growth hormone or prolactin. And obviously when the hormones will rise, the relevant signs and symptoms will occur. Okay? The Cushing disease, we will talk in the next lecture, next hour inshallah. When ACTH more, prolactin more, these symptoms will occur, amenorrhea and galactorrhea, and acromegaly when growth hormone is more. Okay? Means giant size of the person. Sorry? Amenorrhea means menses stop. Okay? But some of the prolactin secreting tumors are silent. Silent means again symptoms are not. Okay? Symptoms are not there. So in short, this may be a complex picture. This may be a complex picture after adenoma occurs, many hormones are more, maybe complex pictures, but usually it's not, usually only one hormone is more, and depending on the hormone, the sign and symptom will occur. Let's go to the specific. Now growth hormone excess. So when growth hormone excess occurs in a adult, we call it acromegaly. And in children we call it gigantism or gigantism, okay? And it is a rare phenomena. And the most cases occurs due to pituitary factor, means pituitary is secreting more growth hormone, okay? But it can be secondary to hypothalamus. Or it can be ectopic tumor production. Okay, now three things. Primary, pituitary, okay? Secondary, hypothalamus. And ectopic means somewhere else, not in the hypothalamus, not in the pituitary, somewhere else problem is there. So all can result to increased growth hormone, all can result into acromegaly. Okay? So lab diagnosis. Now how the patient, usually they are giant people, means they have, due to more growth hormones, their height is more, their build is very, means more than a normal person. So signs and symptoms are there. Okay. So ultimately physician has decided to go to the lab reports. So now we are here. So what we will do in the lab? So random serum growth hormone levels. We will do the random serum growth hormone. We will take the sample and look for the growth hormone. Okay, if the marked elevation is there, too much high from the normal, so we can even label at that point, okay, he has this growth hormone excess. But in 10% of patient, maybe it can fall in the normal reference interval. Means in 10% of these acromegalic patients, the growth hormone may be in the normal range. So in other words, if it is high, it is more in the favor of acromegaly that you can label, but sometimes it can be in the normal range. Second thing is serum IGF-1 level. Okay, it will be high, provide good correlation with the clinical severity of acromegaly. So it is also a good indicator of that. And it is also good for the disease activity and monitoring therapy. What does it mean? That after diagnosis, when therapy is started, so to monitor that therapy, whether this therapy is effective or not, that drugs are effective or not, we can use IGF-1 level. If it is coming down, therapy is good, it is effective. If it is not coming down, it is not effective.
Are this test, doctor, only for children or children?
Both. We are talking about both. First of all, we have just discussed that that acromegaly is in the adults and it is more common. Gigantism in the children, but it is less common. Now this test is more. You are right, in the initial slide we talked, but here it's both, for both adults and children. Now the suppression test. Next step, suppression test. What is suppression? To decrease. We are suppressing something, okay? Now we want to suppress the growth hormone. How? We give the glucose. Just opposite. There we give the insulin. Now we are giving the glucose, okay? So normal subjects show suppression of growth hormone after oral administration of glucose. But person with acromegaly failed to show this suppression. Simple. This is rational. This is the logic of this test. We will give hormone, this glucose. Normal person should respond, and suppression should occur. But if it's not suppressing, it means person has this problem. You want? No. Okay, the same thing is written here. The same. Now this is a flow chart. Just focus on that. Clinical suspicion. So sign and symptoms is first thing. Clinical suspicion should be there. Random IGF level, age and gender adjusted, and growth hormone level. So randomly we now check the growth hormone and IGF-1 level. Okay. Normal levels, no further check. Okay, they are normal. The screening, no need to go further. Elevated. Both are elevated, or one is heavy. Growth hormone level within 2 hours post OGTT, oral glucose tolerance test. So we give glucose orally. Okay. So we then do growth hormone level after 2 hours. Are you getting this point? First we screen growth hormone level, IGF-1. If more, next step we give glucose orally, and after 2 hours we again do the growth hormone. Okay. If it is more, we go for pituitary MRI. Okay, I will come to that. If it is less, no acromegaly. Okay, are you getting? So it is confirming that we want to check the growth hormone, whether patient has acromegaly or not. So screening test growth hormone and IGF-1. If high, then we give oral glucose. Okay. If it is still high, then we will proceed further. If it is not high, we will stop. Clear? Till now? Or any confusion? Just ask me. We are
No, glucose is confirmed.
just glucose confirmed.
The previous 2 hours.
Screening test. This is screening test. We are screening, then we going for glucose. As we did screening, growth hormone IGF, then we went to insulin test. So, okay. Okay. Now pituitary MRI. MRI is done. Pituitary adenoma is there. So growth hormone secreting pituitary adenoma. So there is one diagnosis there. Okay. No adenoma. Then ectopic acromegaly and CT of chest and abdomen can be done.